far as I'm concerned, my diploma says University of Western Ontario. I was working in the emergency department, and now, as some of you may know, London, Ontario, which is where the school is located, is not the most multicultural city in the world. And I was working in the emergency department, and in walked this fellow with his 3 kids in tow. And he was in London. He was visiting from Uganda. And this fellow was so black that he was almost purple. He had the darkest skin of almost anybody I'd ever seen in my life. And he walks in with these 3 kids, and I said to him, "What's wrong?" He said, "My son has measles." And I said, "What do you mean?" He said, "Well, look, don't you see the rash?" And I said, "No, actually, I don't see anything." But so he looked in his mouth, and lo and behold, we could see it inside his mouth. But that was the first time that it occurred to me that skin in people of color was different enough that it was almost a different area of specialty. So when I saw this, and I've been telling medical students this for years, so you can only imagine how great this is for me to have an opportunity to learn from real experts in this field. So the first speaker this afternoon is actually one of my go-to people for people of color, people with skin of color, so to speak, Dr. Manny Raymond, who is a dermatologist in Richmond Hill, which is just north of Toronto, for those of you that are from outside. And besides the fact that he's been an extraordinary help to me, he and I did did it wind up on TV, or was it on YouTube, or? Anyway, we did a video together a couple of years ago. In addition to him being a huge help to me in my practice, he also taught me everything I know about moisturizer. And there are hundreds and hundreds of my patients walking around today who actually know how to moisturize their children properly after I've been telling them to do it the wrong way for about 15 years. So without any further ado, Manny, please.
Now, the green is to make it go forward, I presume, the slides. Good afternoon, everybody. I want to thank the organizers for inviting me, and I'm going to be speaking to you today on onychomycosis, not necessarily a disease that's exclusive to people of color, but there are some nuances to this disease in patients of color that I'm going to try to bring to light in this lecture today. I'm going to go through the faculty disclosure slides as quickly as possible. Onychomycosis, a focus on skin of color. Onychomycosis is an exceptionally common problem. You all see it in your practice. We all miss it in our practices because we don't look at patients' toes. So probably 1 in 6 of your patients will come in with an abnormal looking toenail, of which 50% of these will have onychomycosis. So unless you take a look, you're not going to make a diagnosis. This translates to about 6 to 7% of all of our patients having onychomycosis. So this is an extremely common problem. The majority of us don't look at our patients' feet. Patients come in complaining of things, but we rarely get them to take their shoes off and look at their feet. So if you think about it, you may make a diagnosis, and you may be able to make a significant impact on your patients, irrespective of their skin color. The majority of infections causing toenail fungal infections are caused by dermatophytes. There are other organisms, non-dermatophyte molds, yeast, but the majority of them are dermatophytes. Most commonly seen in toenails, the ratio is probably 10 to 1 toenails to fingernails, but it's not uncommon to see it in fingernails. Certainly yeast infections are far more common in fingernails, but you can see dermatophyte infections in fingernails, especially if someone is immunosuppressed. You may see it more often in the fingernails. There are some geographic variations. Dermatophytes infections are seen commonly worldwide, but maybe in climates where they're more tropical, more moist, humid conditions with occlusive footwear, we may see it more often. Certainly dermatophytes, and absolutely more commonly see yeast infections in those populations. The most significant thing to consider about onychomycosis is not only the physical aspect of the disease, but some of the psychosocial aspects associated with the disease. Most patients are concerned not about themselves, but the rest of their family members. The stuff is contagious. You can leave it on clothing, on footwear. If you share shoes with your siblings, you may be able to transfer it to a sibling. Many individuals will pick it up at a public swimming pool or at the gym, but certainly other family members are at risk for picking up toenail fungal infections from their partners or their children or their siblings. So this is something that's of significance for everyone, but especially for patients of color. Why do I say that? Patients of color, especially South Asians and Asians, tend to live in extended families. So not only do you have your immediate family, but you have your parents there, in some instances, other second-degree relatives as well. So the association of transfer of disease from one family member to another is higher when you have a larger group of individuals living under the same roof. So that's something to think about when you're looking at the feet of your patients with skin of color. Other than the transmittability of this problem, you also have to think about the psychosocial aspect of the problem as well. Many patients are afraid to take their shoes off, they're embarrassed by it, and their partners are embarrassed by it as well. Also of significance is not only the actual fungal infection, but I'm going to show you some data or some slides in a few minutes about some of the other infections that can be associated with fungal infections, specifically bacterial infections. And fungal infections of the toenail and of the skin of the feet does cause skin trauma, breakdown of skin, and these can be ports for secondary infections, more significant bacterial infections, which can sometimes, as you all know, be potentially life-threatening. So here we have Sanjay, but we'll call him Sam for today's purposes, 58-year-old guy with awful-looking toenails. He really doesn't complain of his toenails. It's his wife who brings it to your attention. She is concerned about his toenails. She's also concerned that she may get an infection from him, or their children may get it from him as well. He's a diabetic, well-controlled. He's on numerous medications. He's on medications for lipids, for blood pressure, for mild depression. Typical male, be they South Asian or not, that would walk into your practice in this age group. So as I'd mentioned, the prevalence of onychomycosis, almost 7% in the general population in Canada. Higher in the elderly, much higher in the elderly. Probably 25% of your patients over the age of 65 will have onychomycosis, so very, very common in the elderly. Prevalence also in diabetics, so goes up fourfold in diabetics. So 1/4 of all diabetics will have onychomycosis, not necessarily simply dermatophyte infections. They always tend to have more complex infections, but dermatophytes, non-dermatophytes, yeast, and other organisms may be involved as well. Of significance, diabetes is more common in certain ethnic groups. Certainly in South Asians, diabetes is 4 times more common amongst South Asians, as is cardiovascular disease as well, being 2 times more common. Diabetes, 4 times more common in South Asians, so you can put that together with possible association with onychomycosis. Men tend to be more susceptible than women in North American populations. What's interesting, however, is that the relationship between men and women does not seem to apply in South Asia or in Asian communities. Not exactly sure why that happens. It's thought that maybe onychomycosis is acquired through minor trauma. You're playing a lot of sports, you're getting minor trauma, and that might be a source for acquisition of the infection. Whereas in Asians, mostly in South Asians, it seems that the men and women tend to have equal prevalence of onychomycosis. The overall incidence or prevalence of onychomycosis tends to be lower in Asians, certainly in Indonesia. And we're not, again, sure why the overall incidence of or prevalence of onychomycosis is lower in this population. Again, maybe there's some genetic reasons for that. But what's important to note is that the age association of onychomycosis in these ethnic groups tends to be spread out evenly. So whereas in North American populations, it seems to be the elderly that tend to have onychomycosis more frequently. But in South Asians and Asians, it seems to be right across the board. So you will not see that push towards the elderly having a greater number of patients with onychomycosis. You'll see it in young people as well, probably because they tend to live together and there's more acquisition of disease spread across all family members. So bear these things in mind when you see your patients of color in your practice. I've highlighted a few of these here that may be of import to your patients of color. Diabetes, as I'd mentioned earlier, smoking. Smoking in North America is approximately 15%. So 15% of North Americans smoke. In China, 35% of Chinese smoke. In fact, 65% of male Chinese in China smoke. So that number is over double, almost 3 times what you would expect in North America. Smoking is a risk factor for acquiring onychomycosis, obviously a risk factor for a variety of other things, so you can bear that in mind as well. I'm not going to go through all of these, but there are a whole host of other risk factors that of significance for patients of color and patients not of color. So as I'd mentioned earlier, bear in mind the impact of onychomycosis, the psychosocial aspects of onychomycosis, Onychomycosis, for the most part, does not impact on patients in a painful way, although sometimes if you have whole nail dystrophic change, you can get some pain. But for the most part, it's not painful, but psychosocially it can be impactful on them, and occasionally you can get some occupational dysfunction with onychomycosis. They may feel dirty, they may have more difficulty holding on to close relationships, so all of these things should be borne in mind. Of significance, as I'd mentioned earlier, is the possible association between secondary, more complex bacterial infections that is certainly more often seen in individuals with onychomycosis and with tinea pedis. The number one cause of recurrent cellulitis in individuals is tinea pedis. So if someone presents to you with cellulitis for the second time, you have to make sure that you look at their feet to rule out that they don't have a lingering tinea pedis or an onychomycosis. That's the focus most often seen in these individuals. In diabetics are a special population that we need to really be in tune with when it comes to their feet. And all of you have diabetic patients, and all of you, I'm sure, spend some time speaking about proper foot care with your diabetic patients. And certainly when it comes to onychomycosis, this does play a very significant role in the management of our diabetic patients. Now, if you look at this graph, the association between onychomycosis and gangrene in diabetic patients goes up almost fivefold to just around 1% all the way up to almost 5%. Foot ulcers, again, goes up almost fourfold from just over 1% to close to 6%. And the combination of gangrene and foot ulcers goes up by 100%. Why is this significant? A single episode of gangrene, sounds strange to say that, but a single episode of gangrene is associated with a 5-year mortality of 50% in your diabetic patients. This is far and above greater than metastatic prostate cancer, metastatic breast cancer. 50% of your patients with episode of gangrene will die in 5 years, which is significant. Foot ulcer. 50% of your patients with a foot ulcer will have an amputation within 5 years of something, be it a digit or a foot or a knee, so below the knee. So these are significant numbers, and all of these are compounded by having underlying onychomycosis. So very important that we manage onychomycosis appropriately, especially in our diabetics, in all of our patients, but especially in our diabetics once you add these other more complex issues into the mix. So as I'd mentioned, clinical presentation for the most part is asymptomatic. Unless you have a very dystrophic toenail, it can be uncomfortable and painful. Clinical signs, really, you can see all kinds of clinical signs when it comes to the presentation of onychomycosis, and I'm going to show you some of the classic ways onychomycosis presents. The most common presentation is distal lateral subungual onychomycosis. So this part of the great toenail, typically the great toenail, tends to get injured very, very easily from trauma. So from trauma being the number one source for acquisition of this organism tends to enable the fungus to enter into the space underneath the toenail, burrow its way underneath there, and give you distal lateral subungual onychomycosis. So this is the most common form. 3/4 of our onychomycotic patients will have this form of onychomycosis. There can be other presentations of this form of onychomycosis. Sometimes you can get a fungal spike. It's called an onychophytoma, where you can actually get a spike going from the distal free edge almost all the way down to the proximal nail fold. But this is really the most common form of onychomycosis. Proximal subungual onychomycosis doesn't start at the distal free edge. This starts at the proximal nail fold. This is an uncommon, fortunately rare form of onychomycosis. If you see this, you have to think about secondary immunosuppression. So HIV or some other form of profound immunosuppression. Even diabetics can develop proximal subungual onychomycosis. So if you do see this, think about underlying immunosuppression. It may be worthwhile working your patient up for that. So it's whitish discoloration starting from the proximal end of the nail. Superficial white onychomycosis. This is a relatively uncommon form of onychomycosis. This is the fungus just sitting within the nail plate itself. Typically, onychomycosis, the fungus sits in the nail plate, but also sits underneath the nail plate along the nail bed. This form of onychomycosis, the fungus is sitting very, very superficially. This is actually a very easy form of onychomycosis to treat, actually, so topicals work very nicely for this. Sometimes even just a curette, you can just scrape off the nail, or a blade can scrape off the onychomycotic change within the nail. So this is an uncommon and relatively simple form of toenail fungal infection in order to manage. This is something that we don't like to see, but unfortunately we see it relatively commonly. You all have patients with this in your practice. So about 1/4 of your patients will have total dystrophic onychomycosis. In many of these instances, unfortunately, the nail bed and possibly the nail matrix is also involved, and most of these patients will have permanent destruction of their toenail. So even once the onychomycosis is cleared, they'll be left with an abnormal toenail, which can sometimes be misconstrued as being an active infection. So in these patients, it's important to treat them, but you need to bear in mind that these patients may never ultimately get a normal-looking toenail. Diagnosis, really important to get subungual debris. There's no point in clipping just the superficial portions of the nail and sending it off. You want to get that chunky, juicy material that's underneath the nail. That's where the bulk of the organisms sit. And typically this is sent off for KOH, or potassium hydroxide, and for fungal culture. I also, in order to increase the yield in these patients, will also send off some in a formalin bottle and ask them send it off for pathology as well. And I'll have the pathologist do what's called a PAS stain, periodic acid shift stain, and this increases the yield of my getting positives. The problem is false negatives are relatively common, and sometimes it can take 2 or 3 times before you're actually able to find the organism before you start treating these patients. I must admit, in some instances, if it looks like a duck, walks like a duck, quacks like a duck, it's probably a duck. So if it's typically onychomycotic and I'm not planning on putting this patient on systemics, I will treat them with a topical preparation, the preparation that we're going to talk about in a second, efinaconazole jublia, without actually doing a culture. But if I have in the back of my mind that this patient may ultimately require an oral agent, then I will go ahead and do a culture and look for a positive culture. But making sure you get the right sample before you send them away is very important, because if you don't get the good sample, you're not going to get the positive fungal result that you're looking for. So false negatives are very, very common. So the differential diagnosis of onychomycosis, psoriasis, very common. About 1/4 of your patients with psoriasis will have nail changes, and sometimes that can be misconstrued. Unfortunately, 50% of our patients with nail psoriasis also have onychomycosis. So because they're already traumatized nails, so they acquire psoriasis, or they acquire onychomycosis relatively easily. Nail trauma, here's a classic example of nail trauma, subungual hematoma. Again, once you get nail trauma, that increases the risk for acquiring onychomycosis. Lichen planus of the nails, not something that you're going to see very often, but sometimes this can mimic onychomycosis. Chronic dermatitis along the nail folds especially can give you dystrophic nails, both fingernails and toenails, and can look like onychomycosis. Patients with chronic dermatitis usually tend to acquire more yeast infections because of the breakdown along the nail folds. The proximal nail fold increased development of yeast infections. Something you don't want to miss is a melanoma in the nail bed or the nail fold. This looks like a destructive nail, but sometimes it can look like a hematoma. Sometimes it can look like a classic neoplasm, like a black or a very dark lesion, but this is not something you want to miss. This is something you have to think about in your patients of color as well. Certainly darker skinned patients do develop what we call acral lentiginous malignant melanoma. So if you have a patient of color and you do see something dark on their extremities, it may be worthwhile referring them or performing a biopsy. So if you see a darker patient who, in your mind, would think there is a very low risk of developing malignant melanoma, that is wrong. They certainly can develop melanoma. Pigmented streaks can also be seen in your darker skinned patients. Certainly, sometimes it's just racial or ethnic, and there are some qualities which we're not going to get into as far as the pigmented streaks are concerned, but sometimes that warrants a biopsy. Certainly a Caucasian with a new onset dark pigmented streak in their nail does warrant a biopsy. And finally, bacterial infections, acute paronychia, and sometimes chronic paronychia, yeast paronychia, can sometimes cause a dystrophic nail, which may rarely mimic onychomycosis. So goals of treatment. There are 2 different goals of treatment here. One is the physician's goal, but more importantly, what's the patient's goal? The patient's goal is to have a normal toenail. They don't care that the fungus is gone or better. They just want their toenail to be clear. When we do clinical trials on toenails, fungal infections, we talk about mycological cure. Mycological cure is there is no fungus left in the toenail. That doesn't matter to patients. They want a completely normal toenail. We can talk about improvement of nails, so almost clear, 80 to 100% cure. Some patients, or most patients, will accept that, but most patients want a complete cure of their toenail. And the rationale for doing this is not only to help your patients, but also to prevent some of the secondary complications. Of importance to our patients is that we need to let them know that sometimes it takes a long time for the nail to grow out. So you treat them with the topical agent for a year or an oral agent for 12 weeks, but it can take up to a year or 18 months for that toenail to grow out properly. So they need to wait to allow that nail to grow out properly, okay? So don't be concerned, and assure them they don't need to be concerned if the nail is not better within 3 to 6 months. Current treatment options, a variety of treatment options, oral agents, itraconazole, terbinafine, topical agents, cyclopyrox or Penlac nail lacquer, and definaconazole, Jublia, which I'm going to present to you now. So oral itraconazole, some of you may have had some experience using this oral agent. It does have some side effects. It is an inhibitor of cytochrome P450. There are other agents, and many of our patients are on other oral medications which are also inhibitors of cytochrome P450, such as statins or benzos. Grapefruit juice is also an inhibitor of cytochrome P450. So if your patient drinks grapefruit juice, they may get a relatively increased serum concentration of itraconazole. While on itra, they need to have liver enzymes monitored and renal function monitored as well. The dose of itra is written there. I don't have many patients that I treat with oral itraconazole. Success rate with itraconazole, mycological cure, which is no fungus left in the nail, over 50%, and complete cure, the nail looks completely normal, is only 14%. The gold standard for treating toenail onychomycosis is terbinafine or Lamisil. Works amazingly well. Does have some enzyme inhibition issues, but certainly not to the same degree that itraconazole does. Again, with Lamisil, it's recommended that liver enzymes and CBC being monitored can cause pancytopenias, can impact on the liver, albeit rarely, maybe 1 in 10,000 approximately. Can sometimes give an unusual metallic taste to the mouth, but these are all things that we have to bear in mind when we put our patients with oral terbinafine. Certainly, if they're on other hepatotoxic medications, they may not be candidates for oral terbinafine. The dose is 250 milligrams daily for 12 weeks for toenails, 12 to 16 weeks, and 6 weeks for fingernails. This is as good as it gets when it comes to cure for toenails with terbinafine. 70% of our patients will attain a mycological cure, and almost 40% of our patients will obtain a complete cure after a course of Lamisil, which is a 12-week course of Lamisil for their toenail onychomycosis. Penlac, all of you have had Penlac, use Penlac in your practices. Valiant owns Penlac as well as Jublia, so they're not going to be upset at me when I tell you that Penlac doesn't work. We've all used it. We've all had failures with Penlac. Maybe it works a little bit, but the problem is it's a lacquer. Patients don't use it properly. You have to put the lacquer on. You have to remove it frequently. Otherwise, it builds up on the nail, and it just doesn't penetrate through the previous layers of Penlac. Also, it needs to be used for a prolonged period of time, 48 weeks, as does Jublia. So the problem is if it's not applied properly, it's really not going to work that well. Success rates from clinical trials with Penlac, not too bad. 36% rather patients obtained mycological cure, and 8.5% of patients obtained a complete cure. So this is why we're here today, now that I'm 19 minutes into my 20-minute talk. Topical efinaconazole, so Jublia. So this is a molecule that I had the good fortune of working with about 3 or 4 years ago. Many of you may have had the opportunity to use it. It's a 10% solution. It is very simple to apply, unlike Penlac, which is a lacquer, which you have to paint on. This, you just put 1 or 2 drops. A great toenail requires 1 drop placed at the proximal nail fold, another drop placed along the free nail edge. The other toenails really only require 1 drop with a sponge top applicator. It's a little drop nose applicator with a little spongy brush on the tip, and you just paint it over the nail. Very simple to use, takes seconds to apply it, and you don't need to wash the stuff off. You can just keep reapplying it because it doesn't build up as a lacquer. This product has very low keratin binding, meaning it just penetrates right through the nail and gets underneath the nail. There's some elegant studies that have been conducted by Valiant to show how well it penetrates underneath the nail. It's an excellent, excellent topical preparation for the management of our patients who've got onychomycosis who may not otherwise be candidates for an oral medication or as an adjunct possibly to your oral medication. Mycological cure rates, 55%, complete cure rates of 18%. So here we have the rates of cure in these patients. The studies were done for 48 weeks and then followed up for 4 weeks afterwards. You can see mycological cure rates of 55% here, 59 going 55% at 52 weeks, and 18% at 52 weeks compared to placebo. Now, if I put this into, and here's a nice example of complete cure rates in our patients who were treated with efinaconazole. Surgical avulsion, I'm really not going to spend too much time talking about that. This is really for your patients who've got profound, complete dystrophic nail disease. The problem, of course, with surgical avulsion is that 50% of the time when you remove that toenail, it doesn't grow back properly. So I told you patients with profound nail disease usually have nail dystrophy, permanent nail dystrophy as it is. To touch momentarily on laser therapy, it doesn't work. That's really all I need to say. A variety of different modalities have been tried, from pulse dye lasers, KTP lasers, YAG lasers, you name it, every laser wavelength of light has been tried. They all work, they all don't work. The literature is very poor, it's all over the place, certainly no good randomized controlled trials with laser. It's expensive and it hurts. The only thing we know is that it hurts, because you have to get the nail bed temperature to about 70 to 80 degrees centigrade. So that's hot. So it's like hitting your toenail with a hammer repeatedly. Not a lot of fun. And we're not so sure that it works very well. So really not an option that I have a lot of lasers in my practice at my disposal, but really not an option for our patients. So just looking at all the numbers together now for onychomycosis, this is a mycological cure. You can see topical efinaconazole stacks up pretty well. Certainly it's about the same as oral itraconazole, if not a little bit better, and not quite as good as oral Lamisil, but pretty good when it comes to a topical agent. This is being compared against oral itraconazole and oral Lamisil. Pretty amazing when it comes to a topical agent from a mycological cure perspective, and superior to cyclopyrox, which is Penlac. And from a complete cure perspective, again, pretty impressive. It's superior to oral itraconazole, certainly not as good as a granddaddy or terbinafine or Lamisil, but superior to cyclopyrox, 100% superior to cyclopyrox. So this new molecule, Jublia 10%, is an excellent molecule for the management of your patients with onychomycosis. Certainly for your patients in whom an oral agent is probably not the appropriate therapy for them, and in some of your patients who don't want to take an oral agent for one reason or another. Revisiting our patient, putting all that together, he would really like to try a topical, so we're going to give him a topical. He's on atorvastatin, a statin, which may contraindicate him from taking one of the oral agents, the itraconazole. He's concerned about the side effects of some of the systemic agents, so in his case, I think he would be an excellent candidate for being treated with topical, with Jublia. So finally, 7% of Caucasians, or 7% of North Americans rather, will have onychomycosis. This may be more prevalent amongst South Asians, seems to be less prevalent amongst certain Asians, Indonesians, but more prevalent amongst South Asians due to close living quarters. So if you think about the diagnosis, you will make it. Look at the feet of your patients, and if you do that, you will find onychomycosis, and it will really expand your practice. So thank you very much. Time for questions?
Yeah, do we have some time for questions? Anybody?
For total onychomycosis, do we take the nail off and then put the medication, or what do you suggest?
Excellent question. Yes, yeah, I think that would be a good choice to do if you have total dystrophic onychomycosis, would be to remove the nail and put the topical on underneath it. It's difficult for it to penetrate through all of that keratin to get down to where the nail bed is in order to treat those patients appropriately. But this product is actually pretty good. It gets down there pretty well. You're also going to put it along at the free edge of the nail as well. The issue with when you surgically avulse the toenail is that there is a 50% chance that it's never going to grow back properly. So you have to have that frank discussion with your patient. It's also extremely painful, and you have an open area there. So having an open, exposed area for a few months at least is going to be of significance for your patients. But the best way to do it would be to surgically remove the nail and apply the topical underneath. Yep.
Hi, thanks for your talk. Should we be treating all onychomycosis? Like when you look for it, you can certainly find it, but if it doesn't bother them and if it's mild, do we have to treat it?
Right. Should we treat it? If it's not bothering the patients, do we need to treat it?
Yeah.
I think what I would do is I would give the patients the option. I would talk to them about the ramifications of not treating it, potentially giving to other family members. Certainly in our elderly patients who've got other secondary comorbidities and possibly diabetes, I think it's a good idea to treat because of the possible association with other complications, as I'd mentioned earlier. But do we need to treat in a patient who's otherwise unaffected by it, mild onychomycosis? Probably not.
Okay, great, thanks.
Thanks.
I attended one of your talks, and there you had mentioned for tinea vesicular to take hamburger and Coke and run and sweat it out. So does that help when you give oral antifungals?
I did say that before. So that's for azole antifungals. So with not with topical efinaconazole, although it is an azole antifungal, but with itraconazole or with fluconazole, azole antifungals are absorbed far better when you take it with a fatty meal. And a little bit of Coke or Diet Coke or Pepsi, what have you, because that lowers the pH. And really, that was a talk talking about the management of tinea versicolor. So my formula for managing tinea versicolor is taking itraconazole daily for a week and then once a week for 12 weeks. And when you take it, you need to eat it with fat and Coke and then work out about 4 hours later because the organism lives in the sweat glands. So when you sweat it out, the itraconazole molecule works its way into the sweat gland and kills the fungus in the sweat gland. So yes, important for absorption of azole antifungals.
Can you just comment on the cost for about Lamisil versus the Jublia?
Right. Jublia is not cheap, nor is Lamisil for that matter. Jublia, I think, you guys can correct me if I'm wrong from Valiant, but it's about $70 for a 6 milliliter bottle. 10? 70 for 6 milliliters. Right, $70 for a 6 milliliters bottle. And a 12-week course of Lamisil will cost you around $800 approximately. Right? Is that right? $600? I don't know. Is it less? 300. Do I hear 200? I don't know. 300? Okay.
So when is the best time to apply Jublia? Is it before bedtime or in the morning they put their socks is okay? Or?
Yeah, I usually have them applied at bedtime. It's probably a good idea to apply it then. Yeah, but I don't think it really makes a huge difference, but I think it's best to do it at bedtime. During the day you're sweating, and it's possible that if you get a lot of moisture and sweat, some of the stuff may wash away, but I'd have them applied at bedtime.
Question. I actually just wanted to ask about follow-up after treatment, because if only a small percentage of your patients have complete cure and you're still looking at the nail and only 50% of those patients that still have that dystrophy are cured, how can you tell whether you should continue treatment or if they've been treated already?
That's a wonderful question, the answer for which I don't have. When we do clinical trials, really the data stops at 52 weeks. You treat for 48 weeks, and the data stops at 52 weeks, 4-week follow-up, and they're done. So in the real world, we know that, in fact, these patients are going to continue to improve on an ongoing basis even after you stop it. So although the complete cure numbers are 18%, it's likely that it's going to be higher than that. I don't know when it plateaus off, but it's likely that it's going to continue on for many months after that. Certainly many of these antifungal effects can last for up to 6 months even after you stop them. So the question is, how do we know when to stop treating or how do we know to retreat? It's hard to tell. I mean, really it's patient-driven. If they've got a normal-looking toenail, you're not doing recultures at that time to see if they have onychomycosis still left in the toenail. So although it's normal, they still may have a fungal infection still ongoing into their toenail. But the only thing that our patients are concerned about is my toenail look normal. So once a toenail is normal, you stop. So you treat them for the 48 weeks, and then you wait. You tell them, listen, it may take another 6 months or a year for your nail to grow out normally. So if you wait 6 months afterwards and they're still abnormal, then you may want to consider retreating at that time. Possibly with an oral agent, maybe at that time. If you tried with Jublia and it hasn't improved them with the first go, you may want to think about maybe considering Lamisil for them on the second time, or a combination of the two. Great. Thank you.
So yet again, Dr. Raymond has helped me in my day-to-day clinical practice, because now if I need an excuse to tell my patients to stop drinking Coke and Diet Coke and drink more water, if I tell them that it's a viable antifungal, hopefully that'll contribute to my being able to talk them out of it. just for my own interest, show of hands, how many GPs are here? Awesome. Excellent. And the rest are dermatologists? Okay, so what do the rest of you do? Peds, internal medicine, what do we do? Internist, okay. Any pediatricians here? Interesting. Okay, very good. Anyway, welcome to everybody. Our next speaker is Dr. Charles Chang, who I've not had the pleasure of meeting yet, but he's here and I'm thrilled for that. You probably had the same problems getting here from the airport as I had getting here from Midtown because of the Blue Jays and the Raptors. And he is yet another example of one of the reasons why Vancouver is a great city. It's because all the people from Toronto that moved there and made it a greater city. So he started off with his own general practice, or his own family practice in the early 90s, and his practice evolved into a practice with a special interest in common skin disorders and ultimately aesthetics for the last 20 years or so. He's very involved in academic medicine and has been since 1996. And in his greatly appreciated efforts to make sure medicine is practiced to the highest standards, he's an examiner for both the Medical Council of Canada and the College of Physicians and Surgeons in BC. And he is here to give us our next two talks. And if the organizers want to say something at this point as well, do we want to stop for questions in between the first and the second, or save them all till the end of the second one? Any preference? Any preference on your part? Scream them out as we're going? Scream them out as we're going. Sounds good to me. So without any further ado, Dr. Charles Chang. To first speak about skin disorders commonly encountered in Asian patients. Welcome. Thank you.
I got my little timer here so that I make sure I don't go over time here. I was told they would throw me under the bus if I went over time, so. So thank you for inviting me out here, and this used to be my hometown 25 years ago. I don't recall so many buildings. Every time I come in Vancouver, from Vancouver to Toronto, there's more and more buildings along the highway each time, and I can't even see the lake anymore. Now, I was told that this is a approved program, so I have to disclose lots of stuff. Basically, the U of T CPD program paid for everything today, and I did not receive any support from anybody else. So therefore, I'm not going to mention any brand names or commercial products in any way. I have been paid by a variety of companies in the past. Obviously, I have a special interest in aesthetics medicine, so